are you?
Sinong
Medyo.
may
Hello.
problema? Somebody has a problem?
Naa ka invitation, tapangita.
Hi, Joe.
Oh,
Hi.
si Evan. Evan, good morning.
Kanimo?
Who has may problema yata pumasok.
Good morning, all.
Good morning,
Good morning.
Morning.
Ayan na si Mike.
Dr. Guevara.
Hi.
I-download ang Zoom.
Hi.
Hi, babes.
Download ana, i-click nimo, mugawas na.
Hello, Quaresma.
Hello, we are in California, so it's very early here.
Oh, yes, sorry, yes. Like
Oh.
5:42 there.
Hi, Susan.
Hi,
Hi,
Now you can see everyone now.
Hello. Hi.
Hi, how are
I'm
you?
Monching. Hi, Marlene.
Hi,
Oh,
Becky.
good morning. Ah,
Everybody
wow.
morning there.
Hello, Ramon.
Okay, so Nida,
All. Hi.
good morning again, and everyone, welcome
Hi, this is
to the first ever virtual CME Zoom meeting sponsored by the Philippine Medical Association in Chicago's CME Committee. For those of you who do not know me, I'm Al Estrada, your host and moderator. Let me call the CME Committee's indefatigable chairman, Dr. Nida Blanca-Cernais, for her opening remarks. Nida?
Good morning to all, and welcome to this very first Zoom. Philippine Medical Association in Chicago is Spring 2021 Zoom CME seminar entitled COVID, Everything You Need to Know and More. So we are accredited till 2023, but the year 2020 has been difficult for everyone
We do not see your
because
slides.
of the pandemic. Okay, in 2020 it's been difficult for all of us. So because of this COVID pandemic, so get vaccinated. We will see each other soon. And to all the speakers, our esteemed speakers, thank you for their expertise, for sharing their expertise, their encounters, their experiences, the time and their effort.
Yeah,
Okay, good. Okay, so we'll just go ahead and,
yeah.
okay, Okay, so these are the objectives of the talk, and I'm just going to list the different vaccines available right now in the U.S. We'll characterize the mechanisms on how these vaccines work and describes the reaction that can occur with these vaccines. So basically, this is the current, as of today, about 76 million vaccines has been delivered in the United States. And as you can see, about 2.9 million has been delivered here in Illinois. I want you to know that maybe about 27 million have gotten the first vaccine, and 55 million in the U.S. has not received their second dose yet. This is the structure of the COVID-19 virus, and it's a simplified diagram. And the most important thing that I want you to look at is the spike protein. This is really what makes the difference, and this is where the mutation occurred in China that made it able to be transmitted and infect human beings. So a simple amino acid mutation occurring on the spike protein, especially the receptor binding protein, resulted in in our current pandemic. As you can see on these slides, the spike protein has this receptor binding domain, and this receptor binding domain actually attaches to the ACE2, the angiotensin converting enzyme 2 receptor. It binds to that receptor, and thereby the virus is able to infect different cell types. And the presence of different ACE2, the different cells contain the ACE2 receptor, so that's why it can infect multiple organs. You know, what's an interesting fact about here is that even the nose, there's only a few cells that are present in the nose that contains the ACE2 receptor, but even with very few cells containing the ACE2 receptors, they can, be the primary source of transmission. This is the structure of the COVID-19 mRNA vaccines. The two that are commonly used right now is the Moderna and the Pfizer, and currently it is an RNA. It's a synthetic construct of messenger RNA that basically gives the cell instruction on how to make the spike protein, and it is enclosed in a lipid nanoparticle to make it accessible to be provided as a subcutaneous injection. And it contains polyethylene glycol, as you can see here, and that is important later on as when we describe reactions to the COVID-19 vaccines. So how does it work? So you get an injection, and I hope everyone has gotten their injection, if not the first up to the second dose. You have this lipid nanoparticle containing the messenger RNA. It is once injected, it is incorporated in an endosome. Then it breaks down, and your ribosomes would start to process the mRNA, and you produce a viral antigen. The viral antigen then goes into the proteasome, and the endoplasmic reticulum would encode it and attach it to different MHC class 1 and class 2, which is later on secreted via vesicles, and these are presented on the surface of your antigen-presenting cells, and they will then allow your memory B cells and CD4, CD8 T cells to start producing an immune response against the virus. So again, as you can see here, you have the virus entering the cell, and as different from the vaccine that I showed you initially, it goes into the cell. The messenger RNA is interpreted, and basically more virus is generated of viral RNA, and then you have the virus released that occurs. And then you have your corresponding immune response, wherein you have your helper T cell presentation of the to different antigen-presenting cells, then development of your cytotoxic T cells, which destroys infected cells. You also have long-lived memory B and T cells. I'm going to talk about the different studies, and I'm going to breeze through this, okay? And all of these are published in the New England Journal of Medicine. And as you can see, Pfizer enrolled 43,000 patients, and about half of those were in placebo group. They contain subsets with high-risk patients with obesity, diabetes, and pulmonary disease. So, yeah. Now, here's the primary thing. How effective was the vaccine? It was 95% effective, and that was quite surprising. In fact, the president of Pfizer called up Anthony Fauci when they first got the result and told Anthony Fauci, you better sit down because it's going to, because I have some news about the effectiveness of the vaccine. And when he told him 95%, they were very surprised. In any case, severe disease occurred in placebo group, but none in the vaccine group. Next. And here's the safety data. The only issue with this vaccine is right now you need to keep it in 70-degree freezers, which makes it difficult for distribution. But Pfizer has done studies to show that it can be kept in -20, and that would probably take care of this problem. Next slide. Okay. This is a study that was done in Israel after they started vaccination with the Pfizer vaccine. The most important thing that I want you to know is this last entry wherein you have adjusted rates compared to the unvaccinated. And after starting vaccination with Pfizer, you can see an 85% decrease in the reduction of infection compared to the unvaccinated. So this is after the second dose of the vaccine. This is the Moderna vaccine. Again, 30,000 patients, and you have the high-risk patient included in the in this patient receiving the vaccines. Next slide. And again, and more importantly, as you can see, there were the severe disease. There were 30 in the placebo, 0 in the vaccine group. So it's about 94% efficacy rate. Okay. This is Johnson & Johnson, which was just approved recently. Phase 3 involved 43,000 patients. There were a number of patients from Central and South America, South Africa, the subset with different comorbidities, and that's very important because these are the high-risk group. Next slide. 468 cases of symptomatic COVID occurred, about 100% effective against hospitalization or death from COVID-19, 85% effective against severe disease across all 3 regions. Okay? And next slide. Adverse event, basically 9%, grade 3 fever, 0.2%. No anaphylaxis observed. And I'll talk more about anaphylaxis when we go to the last few slides. And the advantage is it's 1 dose. Okay. So the next one gives you an idea, and I want you to focus on the non-clinical results because they did studies looking at not only the presence of neutralizing antibodies, but also a strong CD4, CD8 protection from challenges. And these were done all in monkeys, but all of the vaccines that are available right now are very effective, not only in stimulating your B cells, but also in stimulating your T cells. And that is very important because viral protection against viral infection is actually related to the amount of T cell response you can generate. That's very, very important. Okay, next slide. This is the data with the different vaccines as we know it. As you can see, protection from hospitalization, most of them were 100%. Now, the 97% for the Pfizer vaccine resulted because there was just 1 patient who got hospitalized. And so that was enough to change the way, the percentage was. And you can also see the number of patients that were vaccinated. Okay. This is a summary of what is available in the U.S. And you can see the effectiveness among people 65 and older, which I hate to say comprise most of the audience in this group, in this meeting. But in any case, the efficacy is about 94% for the mRNA vaccine and 72% for Johnson & Johnson. I was going to call this Janssen Johnson & Johnson because it was actually Janssen Pharmaceutical who makes it for Johnson & Johnson. I apologize for my voice. I caught a non-COVID cold up to 2 days ago, and it's affecting me. Next slide. So I told you a little bit about the importance of T cells and memory B cells. I'm not going to read it. I want you to take 30 seconds to read it yourself while I'm trying to recover my voice. I tend to shout whenever I give a lecture, even though I'm using a microphone. So all of the studies regarding patients or previous patients of COVID, they have been shown to develop a good T-cell response. And more importantly, the ones that have died from COVID actually mounted to stronger response, so to speak, which resulted in some type of cytokine storm. And I know other people are going to talk about that. Next slide. Okay, I'm going to switch gears now and go back again to the mRNA, the messenger RNA vaccines that are currently available right now, Moderna and Pfizer. And as you can see in the structure, there is the PEG lipid that is part of the lipid nanoparticle. Next slide. This has been shown to be responsible for the anaphylaxis that has occurred with giving the vaccines. Okay, and as you can see that there have been 10 cases in the Moderna and about 21 cases of anaphylaxis with Pfizer. 90% of these reactions occurred in women, number one. Number two, so there was 21 patients. 17 patients had prior history of anaphylaxis to either food, medications, or other causes of anaphylaxis. So the 11.1 cases per million, when you compare that to the flu vaccine, the current flu vaccine we have, the incidence rate is 1.3 cases per million. So it's a little bit higher with mRNA. But so far, there has been no deaths from anaphylaxis. A number of those patients was sent to the emergency room, but there were no deaths. Okay, so you have to worry about patients who have anaphylaxis after taking Miralax, which is mostly polyethylene glycol. And in fact, we use Miralax for skin testing these patients to polyethylene glycol. One Moderna vaccine contains polysorbate 80, which is part of that lipid nanoparticle, and it cross-reacts with polyethylene glycol, and that is probably partly the reason why some of these patients anaphylaxed to the Moderna vaccine. Next slide. This is the, I'm going to talk a little bit about the COVID-19 variants in the U.S. This is the data as of February 28. There's probably an increase about 200 for each of those groups here in the U.S. But the most important thing and why I'm showing this is that really these variants can be neutralized by the current COVID-19 vaccine that we have, and so that is very important. Okay, is there another slide? No, I think that's it. One last thing, by the way, and the New England Journal of Medicine reported in a correspondence from Mass Gen that they had a group of patients who presented with a large local reaction a week after vaccination with Moderna, a week after they get a large local red flaming reaction on the skin at the site of the vaccination. And I don't think we need to be concerned about that. It goes away with taking an antihistamine, and after a week, it's all gone. But don't treat it as a cellulitis if you see a large reaction.
Yes, Dr. Tahin Siddiqui, he's an infectious disease specialist.
You guys able to see my screen? Let me
go to slideshow.
Yeah, slideshow.
There you go.
Okay, how's that?
Nice.
All right.
Thank you.
So, thank you. All right, so, as the ritual is, let's start with some pre-test questions. And we will follow up at the end of the presentation, which of these two answers are true and false. All right, so let's start. Ready? Steady and go. Question number 1. COVID-19 reinfection is defined as the clinical recurrence of the symptoms compatible with COVID-19, accompanied by a positive PCR test more than 90 days, that is 3 months, after the onset of primary infection. While COVID-19 relapse, which is defined as recurrence or reactivation, refers to the clinical recurrence of symptoms compatible with COVID-19, accompanied by a positive PCR test within the 90-day period from the primary infection. True or false? Reinfection and relapse. Reinfection more than 90 days, relapse of symptom within 90 days from the onset of primary symptoms.
True.
So what do you guys think? Is it a true statement or is it a false?
True.
True.
True. Okay, anyone else wants to add? If not, let's move to the second question. And we're going to find the answer at the end. Question number 2 is the diagnostic testing to identify patients previously infected with SARS-CoV-2 usually involve the detection of the SARS-CoV-2 nucleic acid by PCR or the antigen test. On the other hand, the antibody testing are authorized by FDA to detect a current infection with the SARS-CoV-2. True or false?
False.
False. Okay. All right. Let's find out. So I like to start first the risk factor that really predispose an individual having the COVID-19 infection. Regardless of the severity of the infection, it could be mild, moderate, severe, or asymptomatic. There are certain categories of patients that we identified are at increased risk to catch the virus. The first of all is the old age. Patient, we know the older age, over 65, are more vulnerable to getting the infection. COPD, cardiovascular conditions, including CHF, CAD, cardiomyopathies, type 2 diabetic patients, obese patient with the body mass index of over 30, patient who has sickle cell disease, from patients who has chronic kidney disease, and the patient who are immunosuppressed from the solid organ transplantation, and the last, cancer patients. This data by CDC is based on the observational studies that these risk factors for patients carrying any of those are more than a normal population vulnerable to catch the infection. My second slide relates to the risk of developing severe infection in COD patient, which is different than catching an infection. A person may not be at the risk to develop or catch the infection, but at the higher risk to develop the severe illness as a consequence. Those areas where we have a certain data to confirm that these patients, if they get infection, they do worse in terms of prognosis and the development of symptoms. Cancer patients, chronic kidney disease patients, COPD patients, Down syndrome kids, patients with the heart conditions, patient with immunosuppressed like solid organs, patient with obesity, body mass index of 30 or less than 40, patient with even 40 BMI, pregnant patient, sickle disease patients, smoking patients. On the side of the column are the patients that we consider they might be at increased risk, but the data is sparse and we don't know for sure that they may or may not be increased risk for developing severe infections. And among those patients who have bronchial asthma, moderate to severe severity, patients with the cardiovascular condition, cerebrovascular conditions, patients with cystic fibrosis, hypertension, immunocompromised but not solid organ, but the blood or bone marrow transplant recipients, the HIV patients, the patient who has been on steroids and other immune weakening medications like biologicals, patient with neurological condition like dementia, patient with chronic liver disease, overweight patient over 25 but less than 30, patient with chronic pulmonary fibrosis, patient with thalassemia, and patient with type 1 diabetes. So if you compare the groups, the patient with older age, patient with the chronic lung diseases, chronic cardiovascular diseases, type 2 diabetes, obesity, CKD, and solid organ transplant, as well as cancer patients, are not only are likely to catch the infection compared to general population, but they are likely to develop the more severe disease. On the other hand, pregnant patients are not necessarily likely to catch the infection, But if they do ended up having infection, they will have the poor outcome, as the presenter before me mentioned. Same thing with the smokers. Catching infection is the same as general population, but the outcome is bad in smokers. Same thing with the patient with the Down syndrome. Not likely to get the infection, or if they do get infection, they'll run a poor, devastating course of the infection. So I want to understand these demographics and the high-risk areas where the patients are likely to get the infection compared to the control groups, and the patients who are likely to develop the severe infection and the poor outcome. Now let's change the gear and comes to the clinical manifestation of COVID-19 infection. The clinical spectrum of the COVID-19 really ranges from an asymptomatic infection to a rather critical and fatal illness. The typical incubation period we considered within 2 weeks. 14 days is considered a of incubation period following the exposure. However, most of the cases in observation, they develop symptoms after exposure within 4 to 5 days of time period. Among the patients who never develop symptoms, the median incubation period is considered about the same 4 to 5 days. However, up to 98% of patients can remain asymptomatic beyond 10 and 11 days. But almost 100% of patients, if they do develop symptoms, they ought to develop symptoms within the first 14 days after the exposure. But as we mentioned, that the first 4 to 5 days after the exposure are the real critical time period. Excuse me. It's estimated that about 33% of patients with SARS-CoV-2 infection never develop symptoms. So about 1/3 patients after the exposure remain asymptomatic throughout the course of the disease. Patients who are asymptomatic, they may have objective clinical finding even if they're not aware of any subjective symptoms. That's important to know, because when you interview these patients, they may not admit having any symptoms. But when do the objective clinical studies, they will have some abnormalities suggestive of an ongoing low-grade infection. For example, in a study of 24 patients who have asymptomatic infections, and they all underwent chest CT, about half of these patients who are asymptomatic, they were found out to have the typical ground glass opacities present. Almost half of them, even if they have no symptoms or not aware of that. Another 20% patient has some abnormalities in the chest X-ray detected. There is another interesting phase of COVID-19 clinical course, which we call the pre-symptomatic infection, other than asymptomatic. Who are these pre-symptomatic patients? Those are the individuals who are not yet symptomatic after they've been exposed, but they will go on and develop symptoms during the course of the disease. They are having a replicating virus. They are contagious, but they do not have any symptoms, but they're in this pre-symptomatic phase. What about the disease severity and the mortality of COVID-19? So as I mentioned, there are 3 major stages. One is mild to moderate. That occurs majority of patients, over 81% patients, they do have mild to moderate degree. The hallmark of the moderate disease are the presence of clinical or urological evidence of a lower respiratory tract infection, but with the blood oxygen saturation over 90% while the patient is breathing the ambient air. These are the patients who usually stays in the mild to moderate zone. And remember, COVID-19 primarily is a pneumonic illness. So it primarily involves the lungs more than other organs too. So mild to moderate infection typically involve the lower respiratory tract, but the patients are not typically hypoxic and requiring any supplemental oxygen. About 14% of the patients, they do progress or sometimes present in the severe category. The indicators of having a severe disease are marked degree of dyspnea or tachypnea as defined by respiratory rate more than 30, hypoxemia, which is defined as oxygen saturation 93 or below on ambient air, the ratio of the PaO2 and the FiO2 less than 300, and the lung infiltrates more than 50% of the lung field involved in the imaging study within 24 to 48 hours time period. If you see the involvement of lung tissue by ground glass infiltrate more than 50% within the first 2 days of the onset of symptoms associated with significant hypoxia and tachypnea and dyspnea, these patients are considered to be behavioral. The hallmark of the moderate disease are the clinical or urological evidence of a lower respiratory tract infection, but with the blood oxygen saturation over 90% while the patient is breathing the ambient air. Another 20% patient has some abnormalities in the chest X-ray detected. Who are these pre-symptomatic patients? Those are the individuals who are not yet symptomatic after they've been exposed, but they will go on and develop symptoms during the course of the disease. Critically ill patients account for a small number, which is about 5% of total. And these are the patients who have multi-system organ failure, shock, and a very high mortality. So literally about majority of patients, over 80%, they do develop mild to moderate symptoms, about 14% severe and about 5% critical and life-threatening. The overall case fatality is about 2.3%. The case fatality rate among the patients with critical disease is about 49%. So yes, the critical illness only account for 5% of the people who got infected, but nearly half of these people died because of infection. Extremely high mortality. The mortality in patients over 65 years of old is about 10 to 27%. Who are between 65 to 84 years is about 3 to 11%. Patients between 55 to 60 years is about 1 to 3%. And the patients younger than 55 count for less than 1% of the total case fatality ratio. Among the cohort of the US COVID-19 cases reported between January to May 2020, the overall proportion of patients who were hospitalized was 14%, including 2% admitted to the ICU, and 5% of those eventually died. Let me go through a tabulated form of these stages of the illness and what basically pathophysiologically happening and what would be the ideal treatment options. As we mentioned, the first asymptomatic or pre-symptomatic phase is the first phase of the illness where patient whether remains asymptomatic or will develop eventually mildly asymptomatic. They are always tested positive by the PCR or antigen test, even they are asymptomatic. The testing is recommended for those patients based on the history of exposure because they're asymptomatic. So the reason they come for testing is usually because of the contact and exposure history, the high risk. Testing by screening by PCR or antigen is recommended for those patients at the time when they present with the history of an exposure. They do need isolation, both droplet and contact, because they have replicating virus which can spread to others. What's going on in this phase is really the early viral replication phase. The virus is in the very initial stage of finding the ACE2 receptor for the binding and for its replication. There is no real potential treatment in the early stage other than monitoring these patients very closely, knowing the fact that they may develop symptoms in the next 4 to 5 days. The mild illness, as we mentioned, patient may have mild degree of fever, cough, low-grade fever, or the lack of taste in the smell, but no respiratory symptoms, including dyspnea or hypoxia. Those mildly infected symptomatic patients, they require diagnostic testing because they are symptomatic. They need isolation because they're actively replicating and shedding the virus. The antiviral treatment like remdesivir is indicated during this phase in order to target the replicating virus. And antibody treatment with the monoclonal antibodies like the Regeneron, and there are the two monoclonal antibodies which were approved by FDA or authorized are indicated in the early phase because they can actually prevent the viral binding at the ACE2 receptor site if initiated early within the 5-7 days from the onset of mild symptoms. And those patients should not be hospitalized, and those patients should have a high-risk category like old age or comorbidities. Moderately severe patients who have clinical or radiological evidence of lower respiratory tract disease or they are desaturating below 94%, obviously they need diagnostic testing, obviously they need to strict isolation immediately. And since the phase in their bodies is still active viral replication, so the antibody treatment with the monoclonal antibodies is highly recommended in those moderately ill patients. The criteria for the antibody treatment therapy is outpatient, patient doesn't meet hospitalization criteria, high-risk patient with age over 65 comorbidities, and that patient is likely to develop a severe disease, but still within the 7 to 10 days maximum from the onset of mild to moderate symptoms. And these therapies are highly, highly effective if administered in the right setting, right patient, the right time. Severe illness, as we define as the desaturation below 94%, or patients tachypneic dyspneic with more than 50% lung infiltrate on the imaging, They do require immediate testing, they require isolation, and they require hospitalization. But the biological phase in the body is not necessarily a viral replication, but the cytokine-induced severe inflammation. So anti-inflammatory medication in the hospitalized setting, including dexamethasone as well as remdesivir, is recommended for those patients who develop the severe symptoms. Critical illness and life-threatening at multi-organ failure and shock, OSD, hospitalization, possibly ICU admission. They are having the cytokine storm, critical care management, dexamethasone high dose, possibly with remdesivir, are recommended. The recent study also advocated using the tocilizumab in addition to dexamethasone for these patients who are requiring supplemental oxygen or invasive ventilation in the hospital setting. And remember, in those patients, the critical part is to really carefully and closely monitor, because as we know, they do progress to the severe and life-threatening illness in over a matter of few days. So what's the initial presentation and based on the common symptoms that we observed during the epidemic? Cough is typically present in about half of the patients who are infected. The cough is initially dry. They may have some mucus production, but a productive cough of purulent sputum refers towards more a bacterial infection than the viral illness like COVID. Fever is observed in about 43% of patients. The fever can be subjective, associated with sweats. I observed in my practice patients reported drenching, profound degree of sweating, especially at nighttime. And that would be, by definition, over 100.4 or 38 degree and above. A typical patient, in my experience, may have 103, 104 fevers associated with diaphoresis at presentation. Myalgia account for about 36% of the patients. Around the same number of patients, they do develop a diffuse headache of mild to severe severity. Dyspnea occurs in about 29% of patients. And the typical time of onset of shortness of breath is about a week after the onset of the initial minimal symptoms. And when dyspnea occurs, it usually indicates a worsening and a progressive disease, because in this phase, the viral infection is now transferred from the upper to the lower respiratory tract, which is a bad sign. Sore throat occurs in a small number of patients, about 20%. GI symptoms account for about 18%, and that includes diarrhea, which occurs in the form of watery stool. I observe up to 20 loose bowel movements a day in those patients, associated with some nausea, vomiting, or abdominal pain. Apparently reported in about 13, 10, and 9% of the frequency, respectively, in that too. But diarrhea, if occurs, is the most profound symptom of varying severity. Loss of smell and loss of the taste, which we call anosmia and dysgeusia, it occurs about less than 10% of the patient. In one meta-analysis, the pool prevalence was estimated to be about 52% for the loss of smell and about 44% of the loss of taste, respectively. These symptoms usually improve within 4 weeks. However, they can last and become chronic in some patients. These symptoms are more usually observed somewhat in the female population than the male population. One of the side note that I wanted to emphasize that many viral illnesses, including the cold, common cold, influenza, can cause the loss of smell and taste symptoms too of varying severity. However, a sudden and profound loss of smell and taste associated with other symptoms is highly suggestive of the COVID compared to the other common cold viruses illness. Rhinorrhea, like flu-like symptoms, occurs really fewer than 10% of the patient, and conjunctivitis has been reported as well, but rarely. A recent study I read this morning actually showed that the active replicating virus can be isolated from the conjunctival secretions and the tears, and that is the foundation of two things. That the tests are being developed to isolate the virus for diagnostic purposes, commercial testing by conjunctival swabs, other than the respiratory swabs, knowing the fact that the active virus is present in the conjunctival secretions and tears. And the second thing we learned from this is the eye protection from a source patient or infected patient is as important as preventing our airways, because the virus can be transmitted through the conjunctiva as well as can be spread to others from the tears too. So how do we differentiate this from the cold and from the flu season, especially this time of the year? As we know, lots of symptoms really are common between the two, but the development of dyspnea and respiratory illness is less frequent in influenza and more profound and more predictable in COVID. In early, rhinorrhea and conjunctivitis can occur with other viral illnesses too, but to a lesser degree, while they are more pronounced in the influenza and other viral illnesses. And the studies have shown that the loss of taste, the smell and the taste, if it occurs early, if it occurs in really a very dramatic and profound way, that favors towards COVID than the other COVID-19. So there is a little clinical scenario where you can clinically predict that this is COVID versus a common cold or influenza virus. Clinical manifestations of COVID are also well reported in the literature and the clinical practice. They account for about 22% patients develop a maculopapular skin rash, which is very diffuse in nature. Discoloration and reddish purple lesions of the fingers and toes, which like chilblains, are also reported in about 18% of the children may present with this kind of this chilblain kind of lesions in their fingers and toes. Hives like urticaria can occur in about 16% of the patient, and as well as a transient form of livedo radicularis. And I'll show you some pictures about these rashes. A varicella or chicken pox-like eruption is also documented with COVID that appeared in about 4 to about 30 days after the onset of the symptoms. Usually not the first presenting feature, but it developed in about median of 10 days. It resolved, but in about up to a month, this kind of chicken pox-like varicella-like eruption is well reported. Less frequently, some patients develop a papulosquamous rash, erythema multiforme type of rash, a dengue fever-like rash, petechiae, and the digital gangrenes. Another interesting syndrome, which I will discuss a little bit later, is the multi-system inflammatory syndrome. It especially occurs in children, which we call the MIS-C syndrome. The cutaneous manifestation of this multi-inflammatory syndrome is erythematous, a polymorphic diffuse rash, erythema, erythroderma, and firm induration of hands and feet, as well as the mucositis involving the oral mucosa, conjunctivitis, and the systemic multi-organ involvement, including the laboratory and findings typical for the Kawasaki type of disease. Some of the examples of the cutaneous or mucocutaneous manifestations of COVID includes these necrotic vascular lesions that we observe. They look like the pressure ulcer, but they are necrotic. And they remind us that vasculitis is a form or manifestation of COVID syndrome. COVID toes, many of my podiatry colleagues have seen and observed these patients present with unexplained lesions on their toes, mainly. And these are called as the COVID toes. And they again represent a type of vasculitis and ischemia. COVID tongue is also reported in literature, and COVID tongue is literally a glossitis, which is acute inflammation and swelling of the tongue. That causes indentation on the side of the tongue. So that's well reported. COVID tongue, COVID toes. The multi-system inflammatory disease in children like Kawasaki can present with the rash on and induration on the hands, feet, as well as the body and the face of the child. So chilblains or pernio, livedo reticularis that we see in autoimmune disorders, lacy network rash, vasculitis, diffuse morbilliform rash, chickenpox like vesiculopustular eruption, hives and urticaria, petechiae, gangrenous and vasculitic lesions. So a variety of cutaneous manifestations are reported in the literature and observed by the dermatologist. So a patient with the COVID can present solely, at least at the beginning, with the cutaneous manifestations of any of these forms to the primary care providers as well as the pediatricians or the dermatologist. Let's go through the clinical spectrum of the disease. As I mentioned earlier, the disease course occurs in children from mild disease. As we know, the children suffer very mild form of disease usually, whether they have no symptoms or very mild symptoms through the course of disease. However, a small minority of children present with the severe acute COVID manifestations, and that include like adults, the pulmonary involvement, including ARDS, neurological symptoms, coagulopathy, and shock. This occurs most commonly in children with underlying medical conditions. Some children with severe acute COVID-19 may actually develop a cytokine storm like adults and ended up in the intensive care neonatal ICU units. The COVID-19 associated multi-system inflammatory disease syndrome in children like the Kawasaki, it usually comprises of febrile inflammatory state. Some children may present with persistent fevers and the mild symptoms like the headaches and fatigue. The inflammatory markers are typically markedly elevated, but signs of the multi-system involvement not yet present. These are the ones which are the early and mild stage of the MIC6 infection. Kawasaki-like disease occurs and reported in especially exclusively children, which meets the complete or incomplete or atypical Kawasaki disease. They do not develop shock and severe multi-system involvement until they progress or present with a severe multi-system inflammatory disease, which really almost identical, at least superficially, with the Kawasaki or atypical Kawasaki disease. So how do we clinically distinguish between the multi-system inflammatory disease in children as opposed to the Kawasaki disease? Points to remember is the multi-system disease in Kawasaki affects mostly in the older children population and the adolescents as compared to the classic Kawasaki, which you see in the infants and the younger children under 5 years of age. So there is an age criteria that we use. If it occurs in the older kids, it's probably related to the COVID, as opposed to the younger kids under 5, it's probably Kawasaki. In multi-system disease, demographically, blacks and Hispanics tends to be disproportionately affected, just like in adults, as opposed to the classical Kawasaki, which we know it occurs most likely and commonly in the children of the Asian descent. GI symptoms, particularly abdominal pain, is very commonly observed and seen in the MIS-C infection related to COVID, while these abdominal symptoms and GI symptoms are less prominent in the classic Kawasaki disease. Cardiac involvement, including the myocardial dysfunction and shock, also reported to occur more commonly with the multi-system inflammatory disease with COVID compared to the Kawasaki. The inflammatory markers, especially the C-reactive protein ferritin D dimers, they tend to be much more markedly elevated in COVID-related multi-system inflammatory disease compared with the classical disease. In addition to that, the absolute lymphocyte and platelet counts tends to be much lower. So lymphopenia, thrombocytopenia occurs relatively more commonly in COVID-related multi-system inflammatory disease than the Kawasaki. What's the clinical course? So some patients who have mild symptoms, at least initially, can subsequently progress with a rapid clinical deterioration that can approximately occurs 1 week after the symptom onset. So if I diagnose a patient with no or mild symptoms, I usually warn them that they may progress rather rapid symptoms in approximately a week from the time of presentation and illness, and they should be very vigilant and cautious for this rapid and sudden clinical deterioration that we've seen in many patients. The median time from their onset of illness to the time they experience dyspnea is about 5 to 8 days. So roughly about a week from the time of onset, average patients seeing the development of dyspnea, that represent the hallmark of progression to the lower respiratory tract, which is a sinister sign and symptom in COVID patients, about 7 days from the onset. The median time from the onset of symptoms to ARDS and full-blown respiratory failure is about 8 to 12 days. So let's say about 7 days from the time of onset. If dyspnea occurs, then an additional 4 to 5 days, the patient may develop respiratory syndrome. The hospital admission about median of 7 days. So about same thing, about a week from the onset of symptoms, median of about 7 days, the patients may need a hospital admission because of the worsening symptoms, mainly respiratory. About 12 days is the time when the patients needs to be admitted to the ICU. The median time from the onset about 9.5 to 12 days too. Among all hospitalized patients, about a third patient of those admitted to the ICU. So always keep in mind that the patient who are hospitalized for varying degree of severity, about a quarter of them will end up in the ICU and may need the supportive treatment, including the invasive ventilation and the breath and the critical care management. The median length of hospitalization typically observed around a couple of weeks. However, we've seen patients being hospitalized for more than that, sometimes 4 and 6 weeks too, if they develop any long-term complications, which we will talk about later. But about average duration is about 2 weeks of hospitalization. Mortality among the patients admitted to ICU is about 39, 42, about 72%. Why there's a variation, about 40 to 72% patients admitted to ICU end up dying, it depending upon the studies and it depending upon the patient population. Obviously, older patient with the comorbidities or late and severe disease at presentation likely to die, and that accounts for patient who on presentation goes on the invasive ventilation and multi-organ failure. The mortality is actually observed to 80% at the time they are admitted to ICU, compared to about average 40 to 50% in most of the patients. So what is the COVID-19 reinfection? The reinfection is defined as the clinical recurrence of the symptoms of the COVID-19 infection, accompanied by a positive PCR test more than 90 days, 3 months from the onset of the primary infection. It also has to be supported with the history of a close contact or an outbreak setting. So there is an exposure also occurs, and there is no evidence of another cause for the infection, like other infectious etiology. Patients who recover from the primary infection are less likely to be reinfected for up to 90 days. So we know that once the primary infection is over, the inherent immunity may last of varying degree for up to 3 months from the primary infection. And that forms the foundation of recommendation. The patient who are initially infected, they should wait for 90 days for the vaccination because they're likely to have some degree of immunity conferred from the primary infection. But if the patient after 90 days present with the symptoms consistent with the COVID, and they know because they experienced it in the first place, they know this is not a different infection. This is exactly the COVID-like symptoms that occur 3 months later. They're positive for PCR, even if they are tested negative previously after the infection is over, they're likely to have the reinfection. There is still limited data exists about the infection rates from the recovery, but the preliminary data shows that the virus from a different strain may be responsible for the reinfection. Serology, by terms of checking the IgG, IgM levels, really does not play a factor in the diagnosis and definition of reinfection. And it could be positive, it could be negative after the initial infection. So the diagnosis cannot be merely based on the positive IgG or IgM titers. You need to do the PCR of the test. And if the facility has methods to gene sequencing to know that this is a different strain behind the second wave of infection or the reinfection. Talking about serology, again, it's really unclear at this point that how long the patient after primary infection recovered from COVID-19 are protected against their initial serological response, what concentration and titers and threshold of the antibodies are required to confer the long-term protection, and how often reinfection can occur after the primary infection. So we still don't know a lot of things about that, but we know that this is very well known in some patients to be reinfected after the 3 months period. And we typically and usually blame for a different variant which escaped, which is called the immune escape from the primary. In Brazil, UK, and South Africa, these variants are reported to be behind the second wave of reinfection after the initial infection 3 months later. Another interesting, of course, COVID occurrence is the relapse. The relapse of COVID or the reactivation or recurrence of COVID is different than the reinfection. Why is different? Because as we discussed before, reinfection occurs after the 90 days with a whole new onset of symptom and a positive testing again. On the other hand, a recurrence or a relapse occurs within the 90 days. So the primary infection, whether mild, asymptomatic, symptomatic, regardless of severity, but the patients then rebound and present within the 3 months with the new onset of worsening symptoms supported by the absence of the epidemiological exposure or other cause too. I've been seeing lately in my practice more and more of patients coming back to the hospital or my clinics with these relapsing symptoms. I alerted my colleagues that they should be really vigilant of those patients who are initially, whether have mild symptoms or asymptomatic, but positive, whether they were admitted to the hospital for mild symptoms, they got discharged after a few days, or they were managed in outpatient. These patients are coming back, and I see some patients coming back after 2 weeks, 3 weeks, and they're really sick when they come with the relapse. They often require hospitalization, they often are very hypoxic, and that occurs within the 90 days from the primary infection. So it's not a reinfection, it's actually a relapse or rebound phenomena that I'm seeing. And I'm very concerned about that because these are the people that think that the worst is over. They got a mild infection, they escaped, they didn't need to be hospitalized, but they then developed the rebound and they really got sick and get admitted. There is a demonstration of the same strain. So it's not a reinfection by a different variant or a mutation. It's the very same strain behind that. That's what the gene sequencing studies have shown. And that is a definitive way to know this is not a reinfection from a mutant strain, but it is actually the rebound and relapse of the infection from the very same original generic strain. An inflammatory syndrome as a result of inappropriate immune response has been blamed as an alternative explanation. So if it's not a different variant, then why some patients actually can relapse really bad. And one theory is that is the immune regulation, that they did develop an immune response after the initial infection, but it wasn't obvious at the time of presentation of the primary infection, but then they got this hyperimmune response within the next several weeks. That's why they get so sick and required often hospitalization. Another interesting thing to remember, COVID is the repositivity of the test. The repositivity of the PCR test means that a positive test following a negative test in an asymptomatic patient, again up to this 3 months period, 90 days from the first episode. So a patient who was initially asymptomatic and then he became negative or she became negative, but then within 90 days became tested positive again. So what does it mean? We've seen this phenomena occurs in some patients that they become tested negative initially, but then after several weeks, they become positive on routine testing. What does it mean? Do they have relapse? No, because they're asymptomatic. Do they have reinfection? No, because that happens within 90 days and not beyond 90 days. Do they have an active virus that is replicating? No. The current understanding is the reason behind repositivity of the test after the negative test. It does not represent the virus is active, replicative, transmittable, and hence these patients do not require isolation as long as they're asymptomatic. The key word to remember is that they're asymptomatic. Diagnostic testing of the COVID is based on the PCR testing, which is about 100% specific and sensitive. The rapid antigen testing is a rapid test of cure, about 15 minutes turnaround time, very specific but not very sensitive. And let me tell you the reason why these tests, which are antigen-based, are of low sensitivity. So, for example, if the patient comes symptomatic to you and you do the antigen test, it's positive, the patient is infected. But if the patient has no symptoms and the antigen test is negative, then yes, the patient do not have any symptoms. However, in asymptomatic patient, the test can be false negative. So we need to remember that a patient who is symptomatic, there is likelihood that the rapid antigen test in the first 4 to 5 days can be false negative. And in that case, you have to repeat the PCR test to confirm the diagnosis. On the other hand, if they're symptomatic and the test is negative, the antigen test, but there is a high index of clinical suspicion, then a PCR test is recommended to confirm the diagnosis. The common lab testing we do for COVID-19 are the laboratory testing, including the CBC comprehensive panel, inflammatory markers, including the CRP-LDH, ferritin IL-6, lymphopenia, neutrophilia, elevated liver enzymes, elevated inflammatory markers are suspected for infection as well as severity of the infection. Elevated D dimers and lymphopenia are associated with a high mortality. Serum procalcitonin, which accounts for bacterial infection, are typically normal in the initial phase, but they can rise in the second phase of the infection. And you always look at the other alternate etiology, especially in flu season, by respiratory panel, looking for influenza and RSV. And the cardiac evaluation by EKG tells you a patient had acute myocardial injury, conduction defect like QT interval prolongation, especially if you're using drugs like levoconazole for the prevention of bacterial infection, and EKG is recommended. Among the imaging, chest X-ray shows bilateral airspace disease. A CAT scan is way more sensitive and specific, but it can still be false negative in about half of the patient who present with the symptoms within the first 2 doses have a normal CT scan. On the other hand, contrary to that, some patients who do not have symptoms may have the CT findings. So it's really confusing to use the CT as a sole tool for the confirmation of diagnosis. The American College of Radiology recommend not to use CAT scan as a diagnostic tool. And then we do the VTE and CT-NG or VQ scan, venous arterial Dopplers, for the patients who are likely to have thromboembolic disease. Some examples of the chest X-ray showing the ground glass bilateral opacities, and the CAT scan showing these ground glass peripherally, not central opacities too. So back to the question again. So the answer to the first question is true. As my colleague mentioned, the reinfection occurs after 90 days, while the relapse or recurrence occurs within the 90 days from the primary infection. And the answer to the second question is false, which means the diagnostic test is for previous infection is serology, while the diagnosis for a current ongoing infection is the antigen or the PCR test. All right, thank you so much, and I'll close my.
Thank you very much, Dr. Siddiqui. Please reserve your questions for the question and answer portion.